Pode pôr. Já tá? Já tá live? Já tá? Hello guys, good morning! Sarà perché ti amo!
Oi, pá, desculpa lá. Estava
Quê?
a ver se isto estava a funcionar.
Muito bem, não, já tá. Okay, good morning guys. Today we start with Sarà perché ti amo, a song that was just reused by the AC Milan fans just to mess a bit with the Juventus fans. And this is a big TikTok music and trend. So we are trendy, and today we want to welcome you again and back to What Would You Do? The third episode of this season 2024. This time Prosto is back, and don't forget, don't forget that you have the chance of subscribing our YouTube channel, Academy by Yad. You have different playlists, so please feel free and join us every Tuesday here live from the Academy. So today we have a special case that was presented here through our social media channels. So it's a patient, a 25 years old patient, of course, a very young patient. He has palate cleft, and of course, the big concern of the patient is actually to restore and rehabilitate an area that is, as you can see here, very, very anesthetic. So finally, after all the surgeries that he's been through, he just decided at this moment, this age, just finishing his studies to finish, of course, his work. So he came to our clinic, and all together with the rest of the team, the surgical department with Professor Shen, and orthodontic department with Dr. Elena, we just started just checking all the information that we had, putting all together and getting the proper diagnosis of this case. So we had three options here. Bone regeneration and an implant and a veneer on tooth 13, and then a full rehabilitation with veneers and the rest of the dentition, at least the anterior upper area. Second option, orthodontic treatment, then a Maryland in single tooth, like tooth 13, and then the 12 just hanging as a cantilever. And then third option, a full rehabilitation of the anterior sector, of course, as well with the Maryland. So let's go through the results. The results just gave us interesting. Some have pointed out the possibility of placing implants, but mainly the results have been to orthodontic and rehabilitation. So how do we challenge the case, and how do we just check the options that we have, and how do we proceed? So when we have this case, this is the initial photo. What we need to see is what are the instabilities of the case. And of course, what you can see here is a big instability in the positioning of the canine. Of course, as you will see further down the road, the presentation, you see that the cleft is right on the lateral. But here, as you can see, there is no canine guidance. Okay, so this is a concern biomechanically. As well, you have a concern as you have a misalignment of the lower that altogether just bring massive bumping and overload of the anterior region, and mainly the central incisors. So going through the rest of the presentation, as you can see, and the initial photos, well, we see the cross-bite of the canine. That was a concern that, of course, for us has to be really managed. Because as you know, we have a main focus in prosthodontics. We want the stability of the posterior sectors to allow a stability of the anterior sectors, anterior rehabilitation. So, and then, of course, this is a mutually protected occlusion, so the anterior needs to protect the posterior. As you can see here, there's a misalignment of the incisors, and here, as you can see, there's the cleft, okay? So, just discussing with the surgery and getting back to the first options of this case, that 19%, just getting back to this photo, just check how we have the relation of the canine. We have a class 1 canine, even, of course, it's a crossbite, but we have class 1 molar, class 1 molar, and class 1 canine. So it's, I would say, a more of a stability of the orthodontic that has to bring this to the prosthodontic to finish the case. So getting back to the first option and discussing it, it was immediately just turned off, because the cleft was exactly in the area and the region that we wanted to rehabilitate, and we wanted, and it was the major request of the patient. Here the patient had composite stabilized acrylic provisional, okay? And so here what the surgery said is, of course, you don't have basal bone, and there's a big instability of the two plates, and of course there's no point of managing a bone regeneration in this area, and of course there's no point, because there's no bone, of planning an implant. So this was just put aside. And we continue with the different option. And in the different option, we just had a treatment done by the orthodontic department. The orthodontic department managed to achieve a better positioning of the canine, but both canine and centrals had a lot of instability to move due to the fact that they were very, very close to the cleft. Whereas all the rest of the dentition had very, very good stability and anchorage to move. So as you see in this picture, maybe you will immediately point out the positioning of the central, that you might feel it's a bit misaligned, but don't forget that the pressure has to be done over a counter pressure. And here with the cleft, there was not such a stability. So the big change was the management of the posterior regions, the management of the anterior relationship between the lower and the upper. And so at the end of the treatment, we just started talking with the patient about what to do and what would be the rehabilitation. And so what we do is we just ask for a walks-up of the from 13 to 23, from canine to canine, and that full mock-up is our guideline, okay? What we usually do in these situations is that we split the mock-up. So we get through different steps of the mock-up, allowing the patient to just choose wisely and with correct information and photographs what will be the best for his case, and actually what you will understand as that is searched for. So here we have the first mock-up. We thought that the teeth were a bit too long, okay? So we adjusted the mock-up, as you can see, to a more rounded, a more better relationship between laterals and centrals, okay? We felt, at the office, we felt that this was a good option, and it was very, very good in the general look of the patient. Here the patient is not shown due to the privacy request that he asked, okay? But we continued. So we continued and we said, well, let's see laterals and canines, just putting aside the centrals. And of course, as you can see here, there's a big amount of concavity and depression here that is just occupied by the material there. So it would be very, very difficult to achieve a good result here because this would be a big, big depression, okay? So what we said, well, let's see the other option, which is only laterals. Even worse, because the canine has no stability regarding the biomechanical stability that we want. Don't forget that we have one tooth that is lost and has to get stability altogether. The literature, the scientific literature says that a case such as this one should be rehabilitated with a Maryland over the central with wing palatal to the central. This is actually today what is, I would say, scientifically the choice, the primary choice. But here we had a problem. And the problem was the fact that we had to compensate the canine, and also the fact that we didn't have that much space palatal on the central. So it would be a big, big difference in terms of the occlusal contacts and the adjustment of the contacts. So we decided, okay, even though the science and the papers say that you should drive your case into one option in one direction, we decided to go in another direction. Yesterday I was discussing this with Andre, in fact, regarding the science and scientific knowledge and scientific content. So this is what we did. This is just a setup of the different mock-ups, okay? You have a full mock-up, a mock-ups, lateral and canine, and only laterals. Only laterals, of course, was just to be obvious not to rehabilitate only the laterals, okay? So what we wanted as a final result was to readjust slightly here the level of the centrals to what would be the acceptance of the patient. Maybe fill up here with a bit of composite just to just cancel this concavity and then rehabilitate here with a Maryland. This is what we did. What is the specificity of this case? As you can see, the edge of the canine is almost edge to edge with the lower, okay? So it means that if I do a prep, an enamel prep such as this one, limited to the buccal area, I have two problems. The first problem is I will have an overload that will have a tendency to just crack the veneer, or just eventually create an overload on the entire tooth. That's the first. The second is, as you have a Maryland, one of the most important parts of the Maryland would be the connector area, okay? If you don't have a good connector in terms of size, length and width, then you can have an issue, okay, on the long term. And again, we also had here, this is the challenge of the case, in fact, because the challenge would be to biomechanically stabilize. So how do we did this? As you can see, we just change the actual contouring of the prep. The normal veneer prep would be limited, I would say, to this, more or less, okay? And what we did was we just got almost to half of the palatal to block any micro movement, okay? And of course, we also condition the tissue here, but by doing this, we can manage a contact through the canine, okay? Even if it's a soft contact, we can manage because we know it will handle. This area will create stability and retention, okay? And altogether, the adhesion on enamel will create stability as well, okay? So this is what we did. We finished the case. we just added composite here. We leveled a bit the central, and we adjusted the level of the lateral on the edge. Okay, and so this is the result we achieved with, as you can see, an outcome that is quite nice, even though we have some limitations on the case. And as you can see here, the depression was here, and this was filled up with composite as well as there. Don't forget that this is actually what we want to bring here. First, the most difficult part of our work as prosthodontists is to be very conservative, very minimally invasive. The second part is to look at the cases biomechanically and drive preps in different directions that allow a better biomechanic. And I think this is something that is really, really interesting. And of course, using materials such as lithium disilicate with, as you can see, a big connector here, a big and long connector, will also be very helpful. I just want to finish just to checking on the lateral movements, okay? As you can see, we wanted the lateral movements to flow without touching the lateral. You can see a contact here and a contact there, okay? So we cannot have an excessive lateral movement over the canine, okay? And for sure, we cannot have lateral movement over the lateral. And when you ask, why have we made and kept this tooth a little bit longer, here is the answer. We have, don't forget, a relationship that between this canine and the lateral in protrusive movements that is not very, very, how we say, very, very comfortable in terms of the overload that you can have here. So we decided to keep this final edge in this position, just allowing not to contact the lateral, okay? So maybe you guys at home, maybe this wouldn't be your choice. Maybe you would go for different options. But what we want to bring with this case is how we approach as a team, how we approach in a conservative way, how we approach the prep and how we look at it in the biomechanical approach, how we use materials, and finally, how we just finish looking at all the movements in the correct way. I would like to thank, of course, my friend and fellow colleague Elena for the work, because this stability is also due to you. And don't forget to follow us on the Academy page. We'll be here every Tuesday with a case. Thank you so, so much.